Pain is the most unwanted thing in the world, but pain is a warning sign. It warns you against the fractures, inflammation like appendicitis, and injuries happening to your body. An absence of pain can lead on to the diabetic ulcers. Okay, pain is good, but suffering from pain for a long time or suffering from pain even after diagnosis is made is not acceptable. International Association for the Study of Pain made an important declaration of Montreal in October 2010, which says access to pain management is a fundamental human right. Because WHO estimates that 5 billion people are in pain, the reason for which is the inadequate pain management in most of the world. Again, the reason for that is the inadequate knowledge of healthcare professionals, that is doctors and nurses, about the mechanisms and management of pain. This particular news came in one of the newspapers in 2014. It happened in Kerala. The suffering of their 9-year-old child forced a couple to kill him before committing suicide. The patient was admitted in a hospital and the patient was a victim of endosulfan. In the suicide note, they wrote that they have decided to take the extreme step because they were unable to tolerate their son's pain. A common thing which we see in post-operative ICUs as well in post-op ward, a male patient, 60-year-old, after total knee replacement of the spine line epidural, screaming in pain, and nurse is least bothered because she's so much busy, engaged in taking care of other patients. And orthosurgeon comments, there will be some pain after a major surgery, you know. Anesthesiologist wonders, before sending to ICU, I gave an epidural top-up dose. Still, what is the reason for pain? The truth is, pain is still inadequately treated. Many of my chronic pain patients have requested me, Doctor, I cannot tolerate this pain. Please kill me. But there are many barriers related to pain management, related to healthcare professionals, that is doctors and nurses, patients and caregivers, and healthcare system per se. The most important barrier related to healthcare professionals, that is doctors and nurses, is the poor assessment of pain. How to evaluate pain? The first question asked is, where is the pain? Second is, how long have you been in pain? And the third is pain continuous or intermittent? You call it as the temporal nature of pain. The fourth is severity. You're going to quantify the pain. How to quantify the pain? There are different methods. One is you are using verbs to describe the pain. You can call it as verbal descriptive scale, no pain, mild pain, moderate pain, severe pain, and excruciating pain. Or we can use numerical rating scale, where scale of 0 to 10, where 0 represents no pain and 10 represents the worst imaginable pain. So after assessing severity, you move on to radiation. Muscular pains as well, neuropathic pains radiate, and even fatal pain like cardiac pain can also radiate. Then you assess the quality of pain. There are different qualities of pain like pricking pain, gnawing pain, cutting pain, burning pain, and so on. And what is the purpose of assessing the quality of pain? It gives you an idea regarding the mechanism of pain, or gives you an idea regarding the pain generators, whether it is a nociceptive pain or it's a neuropathic pain. The picture shows the nociceptive pain is something originating from the nociceptor, and the nociceptor is in everywhere in the body. It can be in the soma, you call it as somatic pain. It can be in the viscera, you call it as visceral pain. Any pain originating proximal to nociceptor is called neuropathic pain. Nociceptive pains, I already said, two types, somatic nociceptive pain and visceral nociceptive pain. The somatic pain is characterized by the sharp nature, hot, stinging, generally well localized, and there will be local and surrounding tenderness. On the other hand, visceral pain is usually dull, cramping, colicky, poorly localized. There may be local tenderness, and referred pains are usually that of visceral pains. Now, coming to neuropathic pain, pain due to apparent somatosensory process in the peripheral nervous system, central nervous system, or both. An important thing is neuropathic pains are often missed or misdiagnosed. Now, what are the manifestations of neuropathic pain? One, the nature of pain: burning, aching, shooting, or lancinating. And it may have a neural or dermatomal distribution. And there can be abnormal sensations like allodynia. Allodynia means when the skin of the patient is touched, patient winces in pain. And there can be hyperalgesia also. A mild stimulus causes severe pain. Another pathognomonic feature is that pain in an area of absent or abnormal sensation is always neuropathic pain. Typical example would be a diabetic neuropathic pain. Patient says, "See, doctor, I don't have any sensation in my feet and hands, but it is paining." So this is a pathognomonic feature of neuropathic pain. Neuropathic pains are classified into nerve compression pain, typically happens with disc prolapse, or nerve injury pain. Nerve injury pain can be peripheral. Examples include peripheral neuropathies and post-herpetic neuralgia. Central pains, examples are post-stroke and spinal cord compression. And sympathetically mediated pain are complex regional pain syndrome 1 and 2. Earlier, they were called as reflex sympathetic dystrophy and causalgia, respectively. This man who had a fall from height and fractured his thoracic vertebra, he couldn't wear clothes, or even the breeze of fan was intolerable because of the severe allodynia, and both the limbs were numb with severe pricking pain. Another example, a 45-year-old man with low backache. MRI shows protrusion of fifth lumbar disc compressing the thecal sac, also compressing the nerve roots. He has shooting pain down the right lower limb with burning sensation. He is suffering from 3 types of pain. One, the inflammational disc leading on to the somatic nociceptive pain. Second, the nerve compression leading on to neuropathic pain. And the third, the muscle spasm. The protective muscle spasm will generate a third type of pain. So in the evaluation, we asked about location, duration, the temporal nature, severity, radiation, quality, and the last one, provocative factors, what increase pain and what decreases pain, palliative factor. How to remember? It is easy to remember the mnemonic PQRST in the reverse order. See, the pain assessment is not complete with this PQRST and LD. You have just assessed the physical pain only. We are interested to know the impact of pain on the function of the patient. So further questions would be, how does it interfere with the normal activities? Activities of daily life like bathing, brushing, toilet activities. How does pain affect the sleep of the patient and ability to walk? The last but not least is the relationship with others, the social, not only social, but also the sexual relationship. So only after you ask these questions, your pain assessment would be complete. So this is the definition of pain by IASP. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. What do you mean by the emotional experience? Okay, when somebody is slapping on your shoulder, there is a sensory experience. Okay, let us say it is 5 by 10. Okay, if your friend comes and slaps on your shoulder, there is a sensory experience with a score of 5 by 10, but because of the added emotional experience, if I am asking you to score your pain, it is 0. But an unknown person is going to give you the same slap. Of course, your score is 10. So why the difference? This is because of the emotional experience coming into. So pain is what the patient says first. So regarding pain, always believe the patient. If I say my pain is 10 by 10, you have to do. You are having only a lesser pain, you are augmenting it. Now, what is somatization? See, when negative emotions like anger or depression are expressed through physical symptoms like pain, it is called somatization. A patient who is having clinical depression, he will be expressing that negative emotion in terms of pain. You ask for the pain score and it is not decreasing because you did not diagnose clinical depression in that patient. So remember, somatization is not the patient's fault, it is the doctor's or nurse's fault. So this man, 50-year-old man, who came with abdominal pain, aggravated by food intake, with occasional vomiting, who was in the surgical gastro department, you can see the CT angio shows the complete occlusion of superior mesenteric artery, and he was suffering from mesenteric ischemia. I went and saw him. In the initial day, I didn't get much time. Because of severe pain, I put him on morphine. And second day when I visited, there was no reduction in pain score. And I found that he looks very much depressed. I asked his wife, and she told me that on the day before his admission, he was missing from the home in the middle of the night. And they went out in search of him, and finally they found him lying on a nearby railway track. I asked him, why did you do so? He told me, doctor, I know that I am going to die because the other doctor told me that my intestines are not getting blood supply, but I don't want to die in distress. So this clearly indicates that he has an element of clinical depression. So I consulted my psychiatric colleagues and he was put on antidepressant like Nexito and also anxiolytic. And with the combination of morphine, antidepressant, and anti-anxiety, his pain could be reduced to 5 by 10. So here comes the importance of finding out the somatization part. We know there is a pain pathway which is going up from the periphery. Similarly, there is a descending analgesic pathway. You can see that it is starting from the periaqueductal gray matter, going down and synapsing in the spinal cord. So its function is modulate the outgoing pain. And the neurotransmitters released are noradrenaline and serotonin. Now, another barrier to pain management is the knowledge. Inadequate knowledge about pain mechanisms and also inadequate knowledge about pain management. Because most of the doctors get little training and hence they are little skilled in pain management. Let us discuss about the management of chronic pain. So this is a WFSI ladder which is shown in the upper part of the slide, which is usually used for post-op pain management. The step one include parenteral strong opioids, the local anesthetics and NSAIDs. Once the pain is reduced, probably on the second day, you move on to oral weak opioids and NSAIDs. And step 3 is oral NSAIDs, usually after 48 hours. But the WHO ladder, which is shown below, is for chronic pain. This is the ladder. You can see it has got 3 steps, step 1, step 2, and step 3. And step 1, it includes only non-opioids and also adjuvant analgesics. You can add or without adjuvant analgesic. And step 2 is adding a weak opioid. Step 1 becomes step 2 when the pain is more. And when the pain is severe, you just replace the weak opioid with a strong opioid. And this WHO ladder was published in 1986 by an oncologist and also by an anesthetist. Initially, it was formulated for treating cancer pain. Now it is accepted for treating chronic pain also. Now, something more about the ladder. You can see it is a ladder and something is written on the top, by the mouth, by the clock, by the ladder. for the individual with attention to detail. By the mouth means, if possible, give the drug through the oral route. It is cheap and simple. By the clock, the drug, depending upon the kinetics, it has to be given around the clock, 6th hourly or 8th hourly. By the ladder, you can move up and down the ladder. If the pain decreases, you can move down. If pain increases, you can move up also. For the individuals, because the drug requirement will be different for different individuals. So individualization of the treatment is essential. And attention to detail means you have to seek for side effects and also complications. And you will tell the patient about the probable complications. Now, what are adjuvants? See, adjuvants can fit into any of these steps. They are not analgesics per se, but with other drugs, they act as painkillers. For example, corticosteroids, dexamethasone, prednisolone. Dexamethasone can reduce headache when there is a tumor. Prednisolone can reduce the perineural edema. Antidepressants and anti-epileptics, they can be used for neuropathic pains. Antispasmodics, they can be used for colicky pains. Muscle relaxants, they can be used for pain due to muscle spasm. Antiemetic, H2 blockers, and all these come under the adjuvants. Now moving on to non-opioid, which comes in the first step of ladder, it includes paracetamol and non-steroidal anti-inflammatory drugs like brufen, diclofenac, meloxicam, indomethacin, etc. Something about paracetamol, also known as acetaminophen. It is commonly used for antipyretic use. Its mechanism is it inhibits cyclooxygenase 3 in the brain. It has also got some peripheral analgesic action. The analgesic dose of paracetamol is 15 milligram per kilogram every 6 hours. Remember, it has only poor anti-inflammatory action and it should not be used for patients with hepatic derangement. And paracetamol can also cause hepatotoxicity. Coming to NSAIDs. NSAIDs are probably the commonest drugs used as painkillers. What is the mechanism of action? NSAIDs block the synthesis of prostaglandins by inhibiting cyclooxygenase enzyme or COX. COX enzymes are of two types. One is COX-1 and COX-2. COX-1 is constitutive, which is present in all normal tissues, especially GI tract, platelets, and kidneys. And in inflammation, its activity increases by 2 to 4-fold. So naturally, the COX inhibition is going to cause gastric ulceration, platelet dysfunction and bleeding and renal failure. COX-2, on the other hand, is an inducible enzyme whose activity is increased by 10 to 20-fold, but it is present constitutively in certain tissues like lungs, brain, kidneys, and testes. And the most important point is that it mediates prostacyclin synthesis, and prostacyclin is a vasodilator and also an inhibitor of platelet aggregation. So, COX-2 inhibition can lead on to vasoconstriction and platelet aggregation. And vasoconstriction plus platelet aggregation is thrombus formation. In coronaries, this can lead on to ischemia and infarction. And in cerebral vessels, it leads to stroke. So, COX-2 inhibition is likely to cause strokes and infarctions. Now, we just go through the classification of NSAIDs. The non-selective NSAIDs inhibit both COX-1 and COX-2. Selective COX-2 inhibitors inhibit only COX-2, and preferential COX-2 inhibitors, they have more affinity towards COX-2. The advantage of selective COX-2 inhibitors, there are two advantages. One is minimal gastrointestinal complication. So in a patient with APD, a patient gives history of gastritis, you may prescribe COX-2 inhibitor. And a patient already on platelet inhibitors like aspirin or clopidogrel, you may go for COX-2 inhibitors. These are the only two advantages of COX-2 inhibitors. And these are the examples of selective COX-2 inhibitors. And etoricoxib is presently the commonly used COX-2 inhibitor. The current recommendation for selective COX-2 inhibitor is use them at the lowest possible dose for the shortest possible duration. Now coming to non-selective COX inhibitors, which block both COX-1 and COX-2, ibuprofen, mefenamic acid, meftad, ketorolac, pyroxicam, and peripheral COX-2 inhibitors, they block both, but they have more affinity towards COX-2. And here comes diclofenac, meloxicam, and nimesulide. And diclofenac is the most commonly used NSAID nowadays. And recently, an article came in British Medical Journal on 4th September 2018, diclofenac use and cardiovascular risk. The study was conducted in Denmark. Duration was 1996 to 2016. And the journal says the incidence ratio of major adverse cardiovascular events at 30 days among diclofenac initiators increased by 50% versus non-initiators. And increases was observed for atrial fibrillation, flutter, ischemic stroke, heart failure, myocardial infarction, and cardiac death, both sexes of all ages, even at low doses of diclofenac. The risk of upper GA bleeding at 30 days, the diclofenac was similar to that of naproxen, but considerably higher than no NSAID initiation, paracetamol, and ibuprofen. So their recommendation is like this. The treatment of pain and inflammation with NSAIDs may be worthwhile for some patients to improve quality of life, despite potential side effects, considering its CV and GI risk. However, there is little justification to initiate diclofenac treatment before other traditional NSAIDs. Now, regarding gastric ulceration, you can see the most safe one is ibuprofen, and ketoprofen causes the highest gastric irritation. Renal failure, remember, risk of renal problems is same with both selective COX-2 and non-selective COX inhibitors. The precautions to be taken are make sure that patient is adequately hydrated, and if there are any chances of dehydration, you have to stop the next dose of NSAID. And it is contraindicated in patients with raised serum creatinine and also patients at risk of renal failure. Now coming to weak opioids, codeine, dextropropoxyphene, tramadol, dihydrocodeine, and pentazocine comes under this classification. Pentazocine is a weak agonist and also an antagonist. It antagonizes mu and agonist at kappa, so it cannot be used for chronic pain therapy. And dextropropoxyphene has been banned. So at present, the most commonly used one is tramadol. Let us see the salient features of tramadol. It has got opioid action. It's a pure agonist, but addition, it has got serotonergic action also. So it is useful for treating neuropathic pain. It causes a lot of vomiting and it reduces seizure threshold. So do not use in patients with epilepsy. Another important thing is that oral route is better than parenteral route. Its bioavailability increases with oral route, but it is a costly affair. Now coming to strong opioids, these are the strong opioids available. Morphine, fentanyl, methadone, hydromorphone, oxycodone, and buprenorphine. Buprenorphine is not a pure agonist. It is a partial agonist. So it is not used for chronic pain therapy. In India, at present, we have morphine, fentanyl, and in some centers, methadone is also available. Now, this is Papaver somniferum, a plant from which the morphine is synthesized. And the name came from the god of dreams, Morpheus. This is son of Hypnos, which is a god of sleep. And the major obstacle for use of morphine are doctors and nurses, because they're afraid to use one of the nature's best remedy because of fear of addiction, tolerance, etc. Its metabolism is peculiar. It is metabolized by phase 2 metabolism by conjugation, and two products are formed. One is morphine 3-glucuronide, we can call it as M3G, and morphine 6-glucuronide, M6G. In renal failure, because these M3G and M6G are excreted through kidney, you have to reduce the dose and also reduce the frequency. Remember, NSAIDs are contraindicated in renal failure and morphine is not contraindicated. Only thing you have to do is reduce the dosage and reduce the frequency. What are the side effects? Constipation is a side effect because it slows down the intestinal movement. Nausea vomiting happens for 3 to 5 days by the time patient develops tolerance. So during that 3 to 5 days, you have to prescribe antiemetic. Drowsiness again lasts for 3 to 5 days only by the time patient develops tolerance. And dryness of mouth can be a distressing one, which can be managed by sips of fluid on and off. And loss of appetite can also be a problem because of this slowing of movement of intestine. Now, respiratory depression. Remember, with oral morphine, respiratory depression is not a side effect. The reason being, the pain is the physiological antagonist to the central depressant effect of morphine. So long as there are pain generators generating pain, if you put patient on morphine, there will not be any sedation or respiratory depression. Now coming to toxicity, this happens when you give morphine to pain not relieved by morphine. Morphine insensitive pains, or if you give too much morphine, that is toxicity. Myoclonus, delirium, and drowsiness. A patient on opioid, if develops dehydration, delirium can happen. And what are the oral preparation? Morphine sulfate tablets, solution, and morphine slow release tablets. This is a sample prescription of morphine. It is given every 4 hours. The slow release tablet is to be given only every 12 hours. So morphine has to be given 6 a.m., 10 a.m., 2 p.m. and 6 p.m. And you give a double dose at 10 p.m. because if you give 4 hours early, you have to wake up the patient at 2 a.m. So to prevent that, you give a double dose at night. And if the patient develops pain after 1 hour of previous dose, you can give a 5 milligram rescue dose. For example, patient develops pain after 7 a.m. You can give an additional dose of 5 milligram, wait for 1 hour, and again can give an additional dose of 5 milligram. This is known as a rescue dose. A pen which writes morphine should also write a stimulant laxative. Bisacodyl, because morphine reduces its intestinal movement. So bisacodyl 5 milligram 2HS is a classical prescription. For 3 to 5 days, you prescribe metoclopramide. And haloperidol is to be given if the vomiting is not controlled with metoclopramide. The morphine causes vomiting through stimulation of dopamine 2 receptors in chemoreceptor trigger zone. And metoclopramide has got some dopamine 2 antagonism. And the most potent dopamine 2 antagonist is haloperidol. That is why haloperidol is given for vomiting, which is not responding to metoclopramide. Now, what are the routes of administration? Oral, rectal. See, rectal route is as effective as oral route with the same dosage schedule. Intravenous and subcutaneous. And sublingual morphine is found to be ineffective. Now, these are the usual concerns. Addiction to morphine. In a carefully selected patient, addiction is not an issue. Now, the question is, suppose the patient is an addicted to drugs, will you give morphine or not? The answer is, the patient is in severe pain, especially cancer pain, you can give morphine, but the thing is that you have to monitor the patient's morphine intake. Second concern is, can we give morphine to non-cancer pains? Of course, but remember, once the pain is controlled, you have to withdraw the opioid and go back to other drugs. And the third is physical dependence. Of course, it is a common thing because physical dependence happens with all the drugs. So a patient who is put on morphine, when it becomes pain-free, you cannot stop morphine all of a sudden. You have to titrate and stop. Now, neuropathic pain data. In the step 1, you can see you start either a tricyclic antidepressant TCA or anti-epileptic drug. If the pain is not controlled, you can add the other one. And NMDA antagonist like ketamine has a role, and also local anesthetic. You can see that steroid can be given in any of these steps. Now, when you prescribe a drug, always ask this question, is the drug affordable? You can see, compare the tramadol with morphine or morphine with transdermal fentanyl. The morphine 24 hours cost only 7 rupees, while fentanyl costs about 300 rupees per day. Now, in addition to pharmacotherapy, there is a definite role for invasive procedures also. Stellate ganglion, especially for complex regional pain syndrome. Lumbar sympathetic block, it is useful for ischemic limbs. Again, we are giving sympathetic blockade with local anesthetic initially and followed by neurolytics. And celiac plexus block is very much effective in taking away the pain due to pancreatic cancer. Epidural steroid injections are tried for pain due to prolapsed intervertebral disc. Now, what is the role of other specialties? Of course, physiotherapy has a role. In the pain and palliative care team, physiatrists as well as physiotherapists have to play an important role. Surgery. In some of the cancer-related pain, surgery can take away the pain. Chemotherapy as well as radiotherapy have their own roles. In a patient with spinal vertebral mass, palliative RT can take away the pain. Meanwhile, you can treat pain with our pain medications. Now, coming back to our earlier patient who was suffering from superior mesenteric artery occlusion and mesenteric ischemia, let me list out his problems. The pain, visceral, nociceptive, ischemic pain from GIT, constipation, hunger pains because he can't eat anything, clinical depression, anger towards whom? Anger towards the medical profession per se, because he says, I did all the investigations you said and now you are saying that nothing more can be done. Fear about the death and also the mode of dying, the financial concerns, the concerns about the family members and spiritual pain. Why me? Let me give different colors. The white one, the pain, constipation, hunger pains, these are the physical symptoms. The yellow one, clinical depression, anger and fear, the psychological sufferings, the financial concerns and family concerns, the social suffering. The last one is the spiritual suffering. So this 4 dimensions of pain is together known as total pain. So when you manage this pain of this particular patient, you have to take away the physical pain. At the same time, you have to do something. You have to address the psychosocial and spiritual pain. On the other hand, by managing psychosocial pain and spiritual pain without giving consideration to physical pain, his pain or his suffering cannot be taken away. Now, in palliative care, we have to take care of other symptoms like nausea, vomiting, constipation, delirium, dyspnea, clinical depression. Intestinal obstruction is a major problem, especially patients who had the pelvic malignancy, incessant cough, or bed sores. In a single visit or two, we come across with few symptoms of the patients, which are just like the tip of the iceberg. But when we make a rapport, you can see more. You can see in the tip of the iceberg, you can see the pain, nausea, insomnia, constipation, etc. But when you go deeper, you can address, you can see the psychological, social, spiritual, and sexual issues. WHO prove the reality. How can we keep the reality close up to expectation? You can take away the pain. You can take away the infection. You can pick out the maggots. So in this way, you can bring the reality line closer to his expectation. Now come the question, let the wound heal. And we know that a malignant ulcer is difficult to heal. So what can we do to improve the quality of life? We know the reality cannot be lifted up. So we have to tell the patient about the truth. And this is known as communicating the bad news. Of course, it happens in different stages. So by narrowing the gap between reality and expectation, the quality of life can be improved. And that is what is being done by a palliative care physician. To sum up, pain management is a multidisciplinary approach, and pain and palliative physician has got a pivotal role. Physiatrist, anesthesiologist, oncologist, psychiatrist, physiotherapist, and psychologist, they have all their own roles in managing pain. Morphine is a wonder drug, and NSAIDs are renal toxic, especially diclofenac, which is cardiotoxic, and paracetamol is good analgesic in the proper dosage. Invasive procedures have also a role. And don't forget about the total pain. Thank you.